a test in a year's time and you are getting a different result. It's not that maybe the initial test you did was wrong, then you are now confused about whether the result is actually increasing. So with efficiency, the ultimate outcome is improved quality of life. And of course, this prolongs lifetime, and it can even be a combination of both. Going further into diagnostic efficiency, we know that it's not just about having an accurate diagnostic process, but that process must also balance the clinical value to the patient and, of course, cost of greater accuracy. And I always use the example of some of the point of care tests that have been, that I've used. I don't know how many of us have that experience, and I hope that. But there are some of the tests that at our lab, at our point of care lab there in Lasut, you could do a test for maybe like a test for the D-dimer. You could do it as low as 3,000, 2,000. But when you send it outside to bigger labs, that same test may cost 10,000, 15,000. And the difference is that when we do our own, we're able to use that result to quickly make a decision. Meanwhile, if you do it outside, sometimes there's to the issue of effective collect a test 1 week later patient now, then what is the effectiveness of actually doing tests? Would have still treated the person whichever way we wanted to treat that person with. And of course, the cost of the diagnostic accuracy does not only include physical costs, it also includes potential harm of the diagnosis. I just gave an example. You might need to wait a week, and by the time it comes back in a week and the data is very, very high, I'll say, oh, you now need to maybe that would have been sent for a biopsy simply because there was a false test. So diagnostic errors include falsely diagnosing patients with a condition they do not have. That's what we call a type 1 error. And then we also have failing to diagnose the patient who may have a condition. So somebody may actually now have actually a high PSA, and because you are doing, using a wrong reagent or using a wrong form of testing, you now tell that patient is fine, and unfortunately the patient is not fine. And years down the line, you now find out, oh, we missed the diagnosis. And we're having a lot of that. I can remember a very promising, and that was what we had. There was diagnostic failure, and by the time the person was diagnosed later, the person already had metastatic cancer. So that's a problem. So an accurate diagnostic process would correctly diagnose all patients who have the disease and none of the patients who do not have the disease. So it's something that we always need to keep at the back of our mind. And of course, we know that diagnostic related errors are quite common. As far back as 2014, 12 million patients were noted to have experienced an outcome from Nigeria. But truly, if we were to look at it, I'm sure it will be probably twice or triple that. Not because we are not good clinically, not because we're not good in our knowledge, because that shows when we leave the shores of the country, but simply because some of the tools and skills we need to quickly make a decision are not there. And of course, we are overburdened with patients. We're going to look at some of the things that drive diagnostic errors. Again, a cross-sectional study, somewhere I think was in Malaysia, among 12 primary care clinics reported prevalence of diagnostic errors of 3.6%. So we may say 3.6% is not much. But if you look at our primary care clinics and the number of patients we see, what is 3.6% of probably 800,000 patients that we see, maybe or monthly, if you take the number of these clinics, that is quite a number of people. And of course, in countries like ours, we still have a problem with data, and the situation is quite down, and of course, diagnostic capabilities. So what are some of the problems with diagnostic errors in primary care? We are a high-risk area because our patients come undifferentiated. Somebody could come, and my observation in Nigeria too is that some of our patients, the way they even describe things, somebody can come, I don't know how many of us have experienced it. There's something in my throat. Somebody wants to say they have, low back pain. Somebody will say, I have jetty. Somebody has chest pain. The person will say, there's something crawling in my chest, So there's a high risk of diagnostic errors, especially for those of us in primary care. And then again, we have high patient volumes. I was still at one of the general hospitals. Was it this week? I was there on Tuesday, and I was there around 2 p.m. and I saw almost, I think, 60 or 70 patients as at 2 p.m. and there were only about 2 or 3 doctors on ground to treat them. So you can just look at the numbers and how patients will now come with different complaints. Because again, another thing that we are seeing in primary care is that unlike in the past, multi-morbidity, where they have different clinical conditions that may not be tied to one etiology, unlike comorbidity. Somebody could have low back pain. You could also have chest pain, or neck pain from spondylosis. You could be diabetic, and then you could now discover that he has hepatitis B. So just imagine the kind of scenarios that you'll be facing when you're in your general, outpatient clinic. And of course, people could come with undifferentiated presenting symptoms, which of course could just be the norm, and they could be benign and self-limiting. I have headache, or I think I'm just a bit feverish, is malaria. Or they could come with even uncommon diseases that could be serious and life-threatening. That's why, again, we need to monitor the trends. For example, one of the new trends now, and one of the new information is that we're having a lot of people coming down with cancer of the colon at younger age groups. So as those of us in general outpatients, we need to be thinking of that and thinking about how do we screen our patients for that. Recently, for example, and it wouldn't have been picked up if people are not really looking at the trends that occur. So again, people will present to either the emergency or the general practice, and we are the ones that help and work in those places. And sometimes another challenge is that diagnosis typically unfolds over time and over several episodes. So somebody could come to me and just say, I'm feeling a bit uncomfortable in my chest. And say, okay, no problems. Go and do this test, come back. But what that person may have is an evolving MI. So later, I've had a situation in the private hospital, a very big guy. He said, okay, well, I have a little bit of chest pain. He was seen by a doctor. The doctor ordered a few tests. The ECG was fine. The person didn't do any of the cardiac markers. And because the ECG was fine, the person said, okay, well, just take a few painkillers, come and see us in 2 days' time. And of course, it became a very, very big issue. And the question now came that if we could have done the cardiac markers and things like that, maybe it would have helped us in our diagnosis. But some people could just have a non-ST elevated, myocardial infarction. So those are the kind of challenge in general practice. And of course, we need to now carefully balance the risk of missing serious illness with use of resources. So somebody comes, you can't order all the tests in this world. He has chest pain. You can't say, go and do a CT scan, go and do D-dimer, go and do troponin, go and do this. You need to still use your clinical acumen. And even if you say the person should do it, you say, please, I don't have money. Are you going to give me money? And then some of these tests are not readily available. Again, pointing to the fact that maybe we should be looking at options like our point of care testing. Again, it is now our role to determine between patients who require rapid investigation, treatment, or referral, and those who will just benefit from, okay, you are fine. I think it's a bit elevated. Maybe the person did a PSA, okay, it's 2. Please come back in so time. I'm going to monitor you again and see whether it's increasing. Unlike somebody you see and say, oh, this patient must be admitted today because this patient is actually quite ill, even if some of the symptoms don't look like that, because you have all the diagnostic tools in your hand to quickly, make a diagnosis. And typically, in a lot of our care centers, a lot of the sophisticated tools that we need in terms of being able to make this diagnosis. So a lot of times now, we now say, okay, come back next week, come back then. And our patients too are becoming more anxious. So they want results. They are not satisfied with you just saying, sorry, don't worry, I think you are fine. They'll say, oh, please, what evidence are you using to make this assessment? Because I was reading social media the other day, I was reading the newspaper, and somebody said he was fine, and suddenly it's not and died. I know somebody that said he was okay and died. So please don't just tell me that I'm fine. So again, as clinicians, we need to look at how we evolve our practice and then make progress with that. So some of the factors, because we've spoken about it a little bit, but I mean, the areas in yellow, I think where I'm going to focus problem for us, be it imaging or laboratory tests. And that's why and point of care is not even just about point of care investigations. I mean, point of care tests which we are going to discuss, but even point of care investigations, ultrasound scan. So we're going to look at all that. And of course, affordability. So if you can get the best options, especially for screening, and the patient doesn't need to pay a hand and a leg to get it done, then of course we'll be able to make progress. Of course, other things coming like coordination and diagnostic errors include here. Everything is still passing beside somebody. You have been treating malaria and typhoid. I said, well, not malaria for our practice. Meanwhile, there are now two that we can use. Most times we just do, once the patient comes with symptoms, we just test. I mean, we just treat because we don't even have clear how disease that we have. Of course, other things include things like myocardial infarction and stroke. I've talked a lot about that. Cancers too are something that, you know, we are missing out on a lot of diagnosis sector. So these are some of the potential interventions that can reduce the global burden of diagnostic errors. Again, a lot of things, but I'll just focus on the key areas so that things like optimizing diagnostic strategy in primary care. So we need to have standard questions, standard questionnaires. We need to examine our patients, and we need to have a high clinical acumen. But more importantly, improving this area, improving access to diagnostic tests. And you can see that they talked about use of high quality point of care testing techniques. Once you have high quality point of care testing techniques, it even helps you for medical legal reasons, where you are able to make a diagnosis and you are sure that you made it not just on your clinical acumen, but based on, you know, some of the tests that you did. And of course, other things include improving information technology, like using electronic health records so that you can look at trends. So I don't want to keep us too long. What is point of care? Point of care testing is routinely used in emergency and, of course, the primary care or general outpatient setting in many countries and across many settings. Complaints about barriers like time, people don't know how to use the machines, and whether, you know, the machine is actually effective and efficient. So those are areas that we need to look at. And point of care testing simply involves clinical tests taken on site at the time of consultation, and with the results being quickly available to be used during the consultation. So just imagine a beautiful process. Somebody came, somebody said, oh, I'm feeling weak. You looked at that patient, the patient looked a bit pale. You say, okay, quickly go and do your PCB, and within 5 to 10 minutes, you've gotten your results and you can make a decision. Unlike, yes, okay, come back tomorrow, and then the person is now coming, you are busy already with a lot of things, and now you now see PCB of 10, or they say the patient slumped outside, and they say, which doctor saw this patient and didn't know that they should have quickly transfused that patient? And you are trying to explain that, yes, I said urgent, but of course, when the person got to the lab and there are thousands of tests, the person just got joined with the other multiple urgent. So we need to be able to do tests. Again, for example, you are running a diabetic clinic. The patient comes, so doctor, I've been using my drugs. You are seeing that the results are quite high. And you said, no, I think you're not doing well. Instead of saying, go and do HbA1c and come back in 2 months or 2 weeks or whatever, you just say, okay, please quickly go and do your HbA1c. And within 5 minutes, you've gotten your HbA1c at 10%. And you say, no, I don't think you're doing well. I think we need to change your drugs. I think those are the kind of things that we're talking about that will even improve our practice and, you know, even make patients appreciate what we are doing. And of course, the point of care tests tend to give a numerical value, and they are gradually replacing, especially in the clinics at general outpatient setting and the emergency, formal laboratory testing. But we must know that point of care test is a little bit different from point of care investigation. So point of care tests usually give us a value. Like, for example, if you say, what is the PCV? It is 21%. Unlike investigations where come out with readings that now need to be interpreted. So that's one of the advantages of point of care testing. And of course, it has the potential to improve clinical outcomes in primary care. Of course, it will help us with prescribing accuracy. We just don't write any drugs, reducing unnecessary referral. Somebody came, you think he has maybe some myocardial ischemia or some angina. You've done all your tests with him. You've told the person that, no, what you just have is a simple chest pain that is due to myalgia. We're going to give you some painkillers and you're going to be fine. You have even helped that patient to overcome all the anxiety that once you tell him. I still told one of my patients, I think that was yesterday, The patient had been doing well, being managed by myself and an endocrinologist for hyperthyroidism in pregnancy. And then, hyperthyroidism. She now got pregnant. So I told her yesterday, I said, well, you need to go back to your, to your endocrinologist to see them. And she said, no, why? What happened? I hope there's no problem. I had to come out and no, we just want a referral. So that's what happens, because in general practice, we already have a relationship with our patients. So sometimes when you are referring them, they think, oh, is the case now more serious? So imagine that you're now even doing a wrong referral. You can imagine what to your own credibility and to your own, just the whole process. Of course, it also maximizes effectiveness of care. And more importantly, especially in this economy where everybody is taking it easy, reducing costs. And I think as clinicians, we must always think of costs for our patients. We have a duty and an ethical duty. If a test can be done cheaper, effectively, and efficiently in somewhere else, doing a simpler method, please let's always go with that method and going for the most expensive test. In my hospital, I had to raise it one day. There's a test that we do for heart failure. We call it Pro-BNP. We use it to monitor heart failure. And we're doing it at our point of care place. I think, was it 15,000 or no, was 8 or 50, I can't remember the price now, 8 to 10,000. And then at another place, they were doing it at almost 60,000. And they were saying, go there. I said, no, the patients cannot go there. Why don't we do it in one place? And so that we have more patients doing the test. We have more results. We use it for our clinical, acumen. And then anybody that says, okay, I have 60,000 and I don't want to join can go elsewhere. We need to really help our patients because, of course, anybody can be a patient. So quickly, I'm going to be discussing as we prepare to round up. Is Nigeria different from other parts of the world? We keep asking ourselves this question. People jackpot as if once you leave Nigeria, all your problems are resolved. But I saw these interesting people that we are going to discuss. It was done in Scotland, and I saw some similarities. In fact, I could imagine myself this setting. And what this study did was, it was a study from Scotland. We can look at it later at our spare time on the barriers, enablers, benefits, and drawbacks to point of care testing. And what they were looking at was a general practice that was doing out of hour service, about 8 to 4. And then if anyone is ill after that, they have to go to the hospital. But now, because the hospitals are becoming overburdened, what they now start doing is that some of them run after-hour shifts. And what they got from this study was that a lot of the things they do here is what they still do there. Urine dipstick testing, somebody comes, sugar level is high, you are looking for ketones, or you think somebody has a UTI, you're doing your urine dipstick, pregnancy test, our oxygen saturation with our pulse oximeter, our blood glucose testing. Those were the most commonly done tests, even in their own GPs there. So that means I, as Dr. Shodipo, I think there's nothing stopping from practicing there. But of course, they themselves also felt that they needed more. Part of the things they needed was, they said they needed things like doing C-reactive protein. A lot of our children, people come down, the full blood count is either here or there. You want to be sure, is this patient really ill? And you just do a CRP, making you get the results in 4-5 minutes, and you are able to make a D-dimer. Oh, I can't breathe, my D-dimer. And if you're thinking of a PE or somebody, and once the D-dimer is low, it's unlikely that person has a pulmonary embolism or a DVT. If you combine your D-dimer with your Wells criteria, 99% of the time, you are able to make a decision on whether to go on to do a Doppler or a CT pulmonary angio, or you just reassure the patient and tell the patient to come back. Those are real life situations. Of course, they also felt that if they had point of care, it would improve confidence, safety around clinical decision, and even patient satisfaction. A lot of people want tests to be done for them to make a decision. They just don't want your clinical acumen alone. And of course, it will also reduce hospital and secondary care referrals. So just imagine that all our PACs had some of this point of care testing. Some of the referrals will get the patient a lot of money moving from one place to another. And of course, those that now really need the care can now be prioritized. And of course, they get that. And of course, we'll discuss some of the barriers that they found as we go on. So again, these were some of the tests that when they asked people, they said we're available. I've listed some of them. Others include, we're able to do a PCV, white blood cell count, troponin, arterial blood gases. But you can see that as it goes down, those were some tests that they were not regularly doing. The mostly done tests were our urine. So yes, that shows that a lot of, even in Nigeria, I think we're also trying. And of course, from my experience in Nigeria, we've seen most of our general practices can do urinalysis, blood glucose, I'm not saying ending to the lab. I'm saying quickly do it and make decision now within 5, 10, 20, maximum 30 minutes. PCV and full blood count, rapid diagnostic test maybe for malaria, for hepatitis B and things like that. HbA1c can also be done. Some centers already. Cardiac markers like my center, we do that a lot. Yeah, we only saw 1 or 2 hospitals did some of the infectious antigens like rotavirus. So imagine that we could have these things and quickly do them. Imagine times we've given wrong prescription of antibiotics to patients that only needed ORS, zinc, and maybe a probiotic. It's really a cause for concern. Of course, some of the perceived barriers in Scotland, which I think may also be our own challenges here. Some patients may not want to do the test, especially it's not a big problem there. But for us, somebody may, but I think if we are doing more point of care, it's cheaper. So even some of those on health insurance, it could be more affordable. Then sometimes, of course, if you are not conversant with tests, you've done a pro-BNP, you don't know what the results interprets, because like your big labs that will write a lot of grammar on the paper, or your point of care testing to give you a number. So you are supposed to now be aware of some of the values and be able to interpret the test for the patient. Concern about, of course, the equipment. Some people feel that some of the tests are not accurate. For me, from my own experience, a lot of times the tests we've done in our own point of care, when they go outside, they get similar results. Or they should calibrate the machines, and there are some people that do that. Additionally, for clinicians in how to interpret the test, I talked about that. Taking time to do the test. So taking time should not really be a problem, because a lot of these tests, as I said, take less than 30 minutes, and then you get your results. And of course, availability of the machine and test kits. Now, this issue of the test kits is a problem, and I hope, like Codex that is doing this presentation, it's an area that I think we need to keep working on for all our companies that do this, because sometimes there's out of stock, and so getting the result is we don't have the, I don't know whether it's the hospitals are not buying or it's the companies that are not supplying. Well, maybe when we get to the discussion part. Again, some of the benefits quite quickly: improve your satisfaction. There's nothing as good as you made a diagnosis, are sure what your diagnosis is, you treated a patient, or a patient came in so anxious. Oh, doctor, I think I have you couldn't do an echo immediately because you need somebody skilled in doing an echo. You've done a BNP and it's normal. You've examined the patient, say, no, you don't have heart failure. Because if you had heart failure, your BNP will be elevated. Try and do your echo 2 weeks time and come back. Imagine the satisfaction you would have. Imagine the satisfaction the patient would have. Of course, it reduces hospital admissions and referrals to secondary care, because you'll be able to make a diagnosis and know those that really need to go. Improve patient satisfaction. I've mentioned that. Helpful when getting advice from colleagues. So you are calling somebody on the phone. For example, if you want to call somebody on the phone and you want to say, I think this patient has MI. You've not done any point of care testing. Okay, what are you using to make the diagnosis? Imagine how difficult it is. Point of care test. This value is this, that value is that. This is what I think. You are having a conversation, and of course, you combine it with your vital signs. You are able to make a decision. Of course, making safer clinical decisions, a major area. Because, for example, if I see a patient coming to the clinic, his leg is swollen. Is this cellulitis? Is this a DVT? Is it unilateral leg swelling? I do my full blood count. Okay, it's a little bit neither here nor there. I do my D-dimer very, very high. Oh, please, I think this is money to do your Doppler. And even if you combine it with the Wells criteria and it's very high, you could even start some anticoagulants and refer the patients while the patient is still looking for money to do, his Doppler. But imagine that you just said, no, I have a patient that had been going to a general hospital, had been managing for cellulitis. By the time we did our D-dimer, it was very high. I said, if this was cellulitis, 2 weeks on antibiotic, no. And by the time we did our Doppler, we saw that that patient had a DVT, and the patient was saved. That patient could have developed a PE and subsequently died. That decision making. So I get more confident. I do my ECG. I'm not sure this ECG is looking somehow. I combine it with another test when I'm thinking of myocardial ischemia, like my troponin, and the patient is having chest pain. I'm able to make a more confident clinical decision, and I'm able to have my patient benefit from me. So please, I want us to ruminate about this for a few seconds, so that maybe we can drop it in the chat box. Maybe we can discuss it. I don't know if there'll be time for that. which point of care test do you think you need? Some of us are working in the emergency in general practice. Please just think of it. I've mentioned some. I've mentioned D-dimer. I've mentioned cardiac markers. There's even I've mentioned HbA1c. For me, those are the critical tests. Pro-BNP. The other day, I was saying that even if I could get something that could do a thyroid and then the infectious diseases, I think I need that in my own center, and I keep fighting that we have that available. So please, just look at yours, think about it, and please let's interact. Drop yours in your center. So other clinicians in Scotland, these were some of the ones they said they wanted, and you can see it's similar to us. You can see one of them here, very interesting, chlamydia. A number of times here, we just even do syndromic management, but they felt that it was a big point they wanted. Of course, some people said no, some people said yes. Pro-BNP, liver function test, HbA1c. So please, let's just think about the ones that we think would benefit us. So there are other solutions beyond just point of care. We need to improve our diagnostic efficiency. We should focus on having relevant information. So please, let's keep ourselves updated, especially for those of us in general practice. There are some apps that we tend to use. I always tell people, use your calculators, use your questionnaires. And because you're in a busy clinic, sometimes decision making is quite difficult. That's not the topic for today, but I always use the opportunity to just talk about it. That, for example, somebody comes, I've mentioned Wells criteria for DVT. Somebody comes, I think the person has depression. I use my PHQ 2 or my PHQ 9, just a questionnaire in addition of care testing can help with. You need to have better communication. Even when people do tests and you're not sure, call them in the lab, call the people that did a scan and just have a conversation. Call the person that did the X-ray and reported it, and have a conversation with them. And then, of course, we need improved technology. Electronic medical records is very important. Very good tests that are efficient. People are able to produce their results. Very, very important. So, in summary, when we talk about efficiency, what we mean is making the best use of information, real time. I mean, what is it really going to do for you? So real-time decision making is very, very important, and this can be achieved through point here. Then, of course, we also can improve diagnostic efficiency when we measure our outcomes. So even us now, we are looking back on how many people actually, we sent for tests and they were negative, and how this helped us to improve our outcomes in terms of but of course, last but not the least, appropriate policy solutions need to be developed locally that will look at these sources of diagnostic inefficiency with a view to correcting them. And that's why, when I speak sometimes I speak on such webinars, but like for colleagues, I've told them that they need to speak a lot to those that are policymakers. I'm happy with some of the new glucometers that are coming out that are a little bit cheaper, some of the machines. But again, apart from all that, I'm talking about point of care testing, especially at the primary healthcare centers, where there's not enough funds to open big labs and things like that. I think some of these tests will help us be happy. These are my references, and thank you so much for listening.
Wow, thank you so much, sir. I really appreciate a very clear delivery of ideas. We're really grateful. I think it's a good point to take questions, or just so that we're more efficient. What we can do is you can leave your question chat, but I see some engagement already. Let me take this question. Mr. Oluwagbemiga, please. I see you have a question. I've allowed you to speak. Thank you. Okay, so while he's getting ready to speak, or I think you can maybe we'll just leave all the messages in the comments, and then I'll just run through just a very short introduction to our solutions, and then we can take them all together. I think that would be a good way to do it. Mr. Oluwagbemiga, please.
Yes.
Are you able to speak right now?
Yes, I can speak now. So, like I said,
Okay,
I
please.
really appreciate the long lectures delivered by our own Dr. Shudipo. On this case of point of care, there's this question you asked us that which point of care or emergencies should be put in place. I don't know if there's a way blood culture and urine culture testing could be advanced into a more shorter time period of testing. Because from the best of my knowledge, blood culture takes about 7 days, while urine culture takes about 2 days or 3 days, depending. So in this kind of test, I don't see how point of care testing put into place. In case of blood and urine culture testing, if it is
I am
possible.
able to answer that because that's the
Okay.
Yes. So there is an answer that I can give because I have the standard F product, which is able to resolve some of those challenges. Now, let me clarify first based on the or a microorganism culture. What you are trying to do is you are trying to isolate and grow a potential pathogen so that you can identify it using usually a microscope or staining method. So I appreciate that and I understand that. But what the standard F200 helps to do is for specific pathogens, it's able to identify their presence or their absence. When clinicians have screened, when the doctors have screened the patient and clicked for, and sometimes it's very important to identify very quickly what it is, or sometimes even to identify what it is not. All right, so in that case, you may have a need to run a single strep A test or an influenza test or virus test, and there are isolated tests like that where the test is made to respond to the presence of a pathogen or an antibody. So that's something that I hope answers that. Now, if it is outside the range of the parameters available on the FIA, maybe for example, it's a like Lassa virus now. The device right now in this moment identify Lassa virus or something like that. And obviously you have to use other methods to do that diagnosis. But I can guarantee you for vector-borne diseases, for respiratory diseases, for STIs like syphilis, like HIV, if you say vector-borne, you're talking about chikungunya, dengue, you talk about strep A, influenza, RSV, all those things can be identified using these devices so that you can save some time from culturing that will have taken so many days. Yes, I hope that answers your question.
Yeah, sure. But I have another one.
Okay.
This
Dr. So please, you can take down your slide.
Okay.
Go on, please. Go on, please.
This point of care testing machines, they are portable. We also have to consider affordability by the users. Then we scientists generally have to be taken along, has to be informed about all these machines. Because a lot of us are skeptical, a lot of us are afraid of the fact that all these portable machines that can be used by just anybody that are not even scientists may be posing a risk to our own job. I don't know whether you get what I'm saying. Like in the case of this
let me speak to that quickly.
Okay.
Do you want to continue your question, or do I answer it?
Okay, like for example, in case of fine test machine being all those stores now, a lot of patients don't go into the laboratory for testing again. They just buy the machines. The pharmacy boys, they train them on how to do the testing, and they test themselves on. I have even cases of some of this pharmacy doing PT, fasting blood sugar for patients, and interpreting the results by themselves. So I consider okay.
Yeah, so let me if and it's good to address this. So the first is globally there's a direction towards self-testing. What it means is that you are becoming more responsible for the things that you do. All right. So what that means is previously, and this is where I believe your concern has arisen from. So when you want to do a test, or you want to from your home to see if you're pregnant or not. Okay? So you can get initial screening results. Now, based on your screening results for pregnancy, for example, you go to a hospital, all right? And then in your hospital, you will start antenatal. They'll probably do a blood BCG, beta HCG test. So what has really happened is self-testing has brought a patient in hospital. All right. Now, in that hospital, they are going to do PCV tests. They are going to do so many other tests. All right, which you know every section of healthcare play a part in. Both the doctors, the pharmacists, the nurse, the lab scientists. Everybody will play in the management of that patient who self-testing has brought to the hospital. So if you look at it from that perspective, what it means is a lot of people who the system may have missed in terms of bringing them to the hospital, self-testing is bringing them to the. In that case, it's not a threat to anybody's job. In fact, it's bringing the people that we went and swore oath for. So you swore an oath to say, I'm going to do this job to the professional best. Just testing has brought the person to you so that you can properly take care of the person. Now, the presentation also highlighted, profiling, which means I set a base level to identify what is wrong with you. What is wrong with the patient, right? Sometimes I don't see anything wrong. In fact, I confirm that there is nothing wrong, right? And that's why screening is good, because if we don't put all the screening measures at point of care or at self-testing level, when something is actually wrong, and we really need every professional in healthcare to step in, then we'll miss the patient. So if a patient is being managed for a heart condition, obviously supporting tests will come in, thyroid function will come in. You understand? Where you are trying to look for secondary causes of this situation, and then that's where you become very relevant, because we cannot do that without you. So I don't think it's a threat. In fact, I think it's an assist, but it's just a case of perspective. I'm very happy that you gave this question, even before I quickly jump into what I'm about to say, in terms of why we are doing what we are doing. But I hope I've been able to answer your question, sir.
Sure. Thanks so much.
Thank you so much. All right. Thank you, everyone, for listening into that conversation. Before I go forward, I don't know if there's anyone who has a direct comment to add to what I've said. Dr. Sho, do you want to address it?
No, I think a lot of what you said is correct. So we need to do appropriate testing. Even when patients are very ill, some of the things, in addition to looking out for the specific pathogen, things like our procalcitonin who can help us, our CRP, we can use that to monitor our patients, our full blood count. They're all critically important. Patients, yeah, so I advise my patients too that it's not just about doing tests, it's about having appropriate interpretation. And so we encourage patients to come to the hospital. Of course, there should be better controls, but I think at the end of the day, we can't throw away the baby with the bathwater. We need the point of care testing in our clinics, in our hospitals, so that at the end of the day, it will even help everybody. And I think it will even help. One thing that you mentioned, that was, I think, Mr. Olukwe, where you mentioned employment. So yeah, it could help. I mean, because we said this, it doesn't mean like the one in our own center is being manned by the laboratory scientists, and but it's just that it's done immediately. So I think if you have it everywhere, people can actually, because the same patient seeing the patient may not have time to go and run the test. So I don't think it will lead to job losses. It may even increase more, because that means, imagine that you have 5 point of care centers in a very big hospital where people can quickly run their tests in various departments. That means people have to manage, and those people, are also going to be paid some money. Yes, thank you.
Okay, all right. Thank you very much, sir. So it's very good to see. I just want to mention a few things, and then we can take more questions, and then we can say that we've had a very good meeting. So this meeting was, called for clinicians with health intervention roles, family physicians, internal medicine practitioners called internists, residents, consultants. And, somebody will say, the topic looks like that's the target audience, so why are you doing that? It's because patients depend on you to tell them what's wrong with them, all right? And patients also depend on you to manage them to evidence improve outcomes. Sometimes the change may not happen outside, but they need a way for you to tell them that they are objectively getting better. A good example would be a patient being managed for diabetes, and you want to be able to say that, look, everything may not look perfect outside, but I can tell you that you are getting better because your underlying risks, your HbA1c, your long-term diabetic risk profile is reducing because you are actually being managed to target or to measure, objectively that there's improvement or lack of it. You can also use that as a tool to encourage patients for better adherence to take their medications when they should take their medications, all right? Because they may not see the direct impact of not doing that today. You understand? They may not see it for 3 months. They may not see it for 6 months. But we need to create a way to compel them that, for the long-term benefits, this is very important. And to this effect, we generally support diagnostic research work in Codex. So if we have healthcare professionals who are interested in research work, research projects, usually, there's a lot of that happens. We offer support. Sometimes the support may be in terms of a discount to the product because what you are doing is not just for profit, but is also for ensuring and making sure that the environment, the health space, health infrastructure is developed. For example, someone in JOS did a very good work on NT-proBNP, and because of that, in that area, a lot of doctors have, imbibed the culture of monitoring patients with congestive heart like symptoms, congestive heart failure symptoms, subjecting them to that test because he was able to find that doing this test was helping him identify patients who were at risk or patients who had mild heart failure or had it in development. So that's also a good thing. And we are supporting facilities looking to improve their profitability and improve health income. So what does this mean? Well, it means that if you have a patient, many times the patient is the victim of failing health infrastructures. So if you don't have a test available in your facility, that patient needs to pay some transport to get to an area or a lab that has that test. All right. Now, you already most likely have a laboratory scientist in your facility that can carry out this test using the same device that's used there. A question was asked to say, are these devices reliable? I can tell you very boldly that in tertiary institutions of notes in this country, you understand the standard F has been used and in many places currently still being used for their devices, for their test results. And so it's been extensively validated because of the general consent to say, can I really rely on this result? And it's been found credible. Just recently, we were engaging with a state government, and the state government was saying that, based on the reports he's received from CMDs of notable institutions, he would like to put this device in some facilities in his state. All right, so when new technology comes in, we trust our laboratory scientists to support us in validation processes. We don't just throw them into the industry. And that's something that Codex offers with its devices that, other companies can learn from, because quality is such an important factor for us. What we want you to remember from this is that there is a clinical benefit of timely screening, which means that if you find it out today, a problem identified is 50% solved. I would like to use that phrase. The reliability of our devices and the partner companies that we work with. Now, almost every device in the point of care space that comes into this country, Codex is first approached to distribute these devices. We don't take all the devices that are brought to us. And the reason is very simple, it's very clear. It's because we want to know the validation reports it has. We want to know the level to which these devices are being improved. We want to know the global reputation of the company that is bringing this device into the country. And so we don't just touch anything. We don't just put our hands on any product. No, we work with partners that have proven track record of credibility and people who are not in this industry just for profit alone, but actually to touch lives. And then we have a commitment to support affordability and long-term cost reduction. And that's through our localization plan. So for most of the devices, most of the products that we have, we believe that in the short to medium term, we will be able to, at some point, be able to produce this currently in country. Earlier today, we had a training that we are doing in a tertiary institution in this country, where we've introduced a course that never existed on nanotechnology. And we are training the next set of scientists to be able to be industry ready in terms of research and development, in terms of developing test platforms. That's something that nobody has ever done before. Very few people will do after. But that's our commitment to making identified, benefits of working with us. I just want to add that we give lifetime technical support on all devices that we sell and provide. So what that means is, if you work with Codex, and by choosing Codex, if something happens to your machine, you are not alone. All the other areas have been extensively spoken about. I will just highlight very quickly some areas that I think we can all benefit from, and then we'll leave it at that. We have solutions for chronic diseases like diabetes and kidney function. Inflammation, we have PCT, and the PCT works both from serum and for blood, CRP as well. We have cardiovascular parameters, we have blood-borne or sexually transmitted parameters, tumor markers, hepatitis of all kinds, gastrointestinal diseases, hormonal parameters, respiratory parameters, and vector-borne diseases. What this means is that you can speak to the sales representative close to you to ask for more information of how you can do more with your standard F200. I think this will be a good place to wrap up and maybe have more questions, and then we can call it a good meeting. I see a raised hand. Hello, sir. You have a question? Hello. I see a raised hand in the chat.
Yes, it's me.
Yes.
I want to ask a question about F200 machine.
Yes,
is it temperature dependent? And how do we cook? Is it temperature, the use, is it temperature dependent? And how do we cook? Yes, how do we cook with its usage, especially at this time when electricity supply is so poor?
Okay. So there are simple benefits. In Nigeria today, some things have been done to help health systems function optimally. One of them is the integration of alternative energy sources into the operations of hospitals. And that helps a great deal in terms of making available power for essential functions like laboratory testing. Now, because the F200 is a low power consumption device, it will fit very perfectly into those settings. So you can use an inverter, you can use generator, you can use solar energy, and it will still work effectively. The second question you asked is relating to temperature control. Yes, it is true that, like every sensitive equipment, I mean, these analyzers are not, of any low quality, and so they need to be kept with utmost care. So we usually recommend that they are opted in 10. Room temperature is fine. You don't need to be in a freezer, but obviously, the analyze on what device to get to your sample as well. If there's a organism and then your temperature is so high, you could kill the organism and then give a false result. So based on that, it will work at temperature, and it will move in that. Hope that answers. All right, thank you very much. Right. The team, maybe from experts present, from the visiting attendees will be able to more funds and otherwise and quality good meeting. Something from management who will be very happy to interact with customer directly. I'm just going to allow him to speak. So his name is Mr. Tunji Oloyede, and so I'm going to allow him to speak now. Tunji, are you able to speak? Speaking is
Good afternoon.
Thank you. Thank you very much for the presentation. Really appreciated the time, the speed. In fact, the texture of everything you said just made so much sense to me. What do you think we can do to really to really help that process? You know, it's beyond talking, it's the value now, right? What should we be doing?
Yeah. Thank you so much for that question. Truly, it's something that I've had a lot of conversations on. But I think for me, first, we need to show that it works. And when I say it works, I'm not talking about the machine now. I'm talking about the outcomes. You know, so we have a number of centers where these machines have been deployed. I always use an example of lawsuits because I always like speaking to what I do. Sometimes, you know, you can come and talk and they'll ask you, okay, this, what you are even saying, have you ever done it before? And you say, no, I just read about it, or I mean, I heard about it. So, for example, I think some of the experiences we have from some of the centers that are already practicing this, we need to let the clinicians know, and then we need to let the policymakers know. So I'm happy that there's been some engagement with the government, but I think we need to take it at each level. First, at the level of the primary care, which they should see it as their own ownership because they have the greatest challenge in terms of having laboratory support for whatever they are doing. And of course, when we now look at the cost potential, and I always tell people to even encourage clinicians because sometimes I've seen a number of my colleagues that don't want to work at primary care because I feel that people don't value the work I do. The patients too don't value the work that is being done because they just feel, for example, you write a drug, you never asked for a test, you never did anything, so they move. So I think we need to look at the level of the primary care, the PHC board, secondary care, and of course tertiary care, and the level of the Ministry of Health. So that's on one side. And then even for the private practice, which is critical and key, I think there needs to be a lot of interaction. I think there needs to be a lot of interaction in terms of with the Association of Nigerian Private Medical Practitioners. A lot of them, at least from the interaction I've had lately, are really looking for some of these solutions and some of these options. And while we are doing that, we also allay the fears of other health professionals, like in the lab, and to let them know that, well, it's not about, it's all about the end point, which is the patient. And I keep telling everybody, God forbid anybody could be a patient. And I had a chest pain now, I want to be sure that they could quickly be sure it's not a heart failure, or maybe not heart failure, it's not a myocardial infarction. So I want to be sure that wherever I find myself, I must not find myself in lawsuits. Even if I'm somewhere in Egbeda, somebody should be able to do a point of care test and know your troponin is fine, do an ECG for me, you know, at that level, and now say, okay, please, you can now subsequently go to lawsuit. Not that nobody even knows what is going on and the person, you know, dies or there's panic and so I think we just need to keep driving the message. But please must provide evidence, because without evidence, people are going to think you are doing it for marketing purposes, not just doing that. Actually, these are things that could, you know, move the conversation forward. And it's not just in Nigeria. I just gave the sample of the study in Scotland. They are also having the same problem. And that's why somebody came out with that study. That's a 2024 study. So please, I think since you support research, I think you should work with, you know, some of our institutions. It mustn't be a big research, just your simple retrospective audit. How many tests have been done? Which departments did they come from? You know, and I think that would move. So when you are presenting to the commissioner, to AMPMP, to our colleagues, there's evidence. It's real. It's not something that is imagined, or somebody could say, maybe you paid Dr. Shodipo some money, so he's just coming here to come and say what will suit the company. No, these are real things that I think we need to do, and it will lead to even less people sometimes traveling out. Some people simply travel out because they're not satisfied with the practice they have here. They don't get that sense of satisfaction. So I think I'll stop there. And thank you so much for the question.
Fantastic answer. Thank you very much, Dr. Shodipo. I think everything there for me to do. Thank you.
Okay, thank you very much. Standards in the industry, so that you can deploy point of care